Welcome back to our live Get Expanded discussions. Our mission is to bridge the gap between patients and providers and provide answers to your questions around airway health, jaw development, and expansion-based treatments. Tonight, we have a special expert, no other than Dr. Svitlana Koval, an airway-focused orthodontist known for her MARPE F.A.C.E protocol, which is exactly our topic for tonight. And of course, hosting the call with us, Girl Jaw, a subject matter enthusiast, a patient, and a patient advocate. Be sure to check out her expansion journey on all her socials. I'll leave all that in the description box below. As always, we'll wrap up with a live Q&A. So feel free to drop your questions in the chat and we'll try to get through all of them by the end of this call. I think we have about an hour and such. We'll drag it as much as we can. Without further ado, Girl Jaw, I'll pass it over to you.
Awesome. Well, hey, it's nice to be back, Patrick. It's nice to meet you, Dr. Koval. I am super excited to discuss MARPE F.A.C.E tonight / this afternoon if you're in California like me. And yeah, hear all about it. So first things first, I just wanted to clarify. So you have a practice in Southern Florida, that's correct?
Yes, that's Boca Raton. It's about an hour north from Miami.
And what is your practice called?
It's Dr. Koval Orthodontics. It's very straightforward.
Okay, awesome. That way people know how to get in touch with you. And then you are also a big contributor to the Facebook Adult Maxillary Expansion Group. And so if you guys aren't a part of that, do check it out. She periodically chimes in to answer some questions. But without further ado, let's just get right into it. MARPE F.A.C.E, I'm really curious about your protocol. I know it's pretty standard. It's MARPE, but after watching you talk with Ron on his podcast several days ago, you talked specifically about things that you do to make it the MARPE F.A.C.E protocol. And I remember when you first launched the trademark name, as a woman, I thought that was really cool because you have hinted here and there about like enhancing aesthetics and anti-aging. And so I'm wondering how that all, as you present, if we'll touch on that, how that all will come up in what you do. So I want to give the floor to you so I can hear all about it.
Perfect. Thank you. Thank you, Girl Jaw. And thank you, Patrick, for this introduction. Yes, I will have a little introduction myself about the MARPE F.A.C.E and why we came up with this name. So as you all know, MARPE is like a very big umbrella term for all sorts of expanders that are screwed or just anchored to the bone with the help of the mini screws. So just like we know, FME is one of those, and MARPE is not necessarily limited to custom MARPE or a specific design of the appliance, but rather we use this term to kind of refer to all the treatments and all the steps that we use starting from even age 3 or 4 and to adulthood. So that this protocol involves expansion and mandibular advancement, and at different ages, we use different sorts of expanders. So as you know, my practice is it's totally dedicated to all sorts of expansion. And we specialize on different appliance designs, on different techniques and different modalities and combinations, and to make it as efficacious in different ages. And we use that for treatment of sleep disordered breathing at different ages, and specifically for treatment of obstructive sleep apnea in adults. So I will start with just the overall kind of idea of what that is. It's a protocol of a facial development and treatment of sleep disordered breathing in children and adults. So what we want to do here, we want to develop a nice face. We want to have the mid-face developed with expansion, with the guided movement of the facial bones. And we want to guide the mandible to follow that to kind of come up with a nice balanced facial profile. So that entails at least 2 years of treatment. And when I say at least, I'm not meaning that it can be 5 years of treatment. I'm saying that the average duration of this sort of treatment would be 2 years, and it will not be limited to expansion alone. So expansion is always enhanced with additional movements, and it's always corroborated with the mandibular manipulations like expansion with remodeling and advancement, of course. So uh, we specifically focus on facial enhancement because that is a part of what we do. And with the everyday focus on improving these protocols, on developing and working on what can be done to improve the outcomes, we've noticed that a certain degree of midfacial expansion that we do in adults, that inevitably results in improvement in nasal breathing. But as we move on, as we move further with that expansion, we, on top of having the benefits of improved nasal breathing, we do see a lot of improvement and a lot of enhancement in terms of facial aesthetics. And we have come up with specific, I would say, guidelines for females and for males of where and how far we want to go in females and in males in particular, depending on their facial structure. So it's not a unified protocol for everyone. It's going to be very different. And what I want to start with is that these pictures that are all over the internet. Yeah, I was just like playing around. We are we're far beyond what was just kind of basic years ago, and we're moving, and we're forced to kind of master all that AI that is surrounding us. So there is no longer we're no longer kind of bound and restricted of whether this expansion, the facial expansion, splits or not. We are looking of what can be done further beyond that split. So what I'm saying is that there is no question that with the MARPE F.A.C.E protocol, the palate and the midpalatal suture would split, and our success rates are approaching 100% in adult patients. I'm not talking about the adolescents, and I'm not talking about growing patients. It's out of question at all. But for adult patients, regardless of their age, gender, and all sorts of midpalatal suture maturation, this is not something that would alter or kind of challenge this midpalatal split. It will happen due to the combination of what we do to make it happen. So now the question is, what are we looking into after that split happens?
Yeah, and can I ask you a question about the piezocorticotomy? So are you doing that on every single patient, every single adult patient?
So my cutoff line is to do piezocorticotomy on everyone who is 18 and older.
Gotcha.
Yes.
Yeah, just checking, because I've had it with both of my expanders. I had a piezo puncture and then a piezocorticotomy with the second one. But I personally think it's just such great insurance to take out, because like, why not, if it's going to help you get closer to success, especially if you're a man or a male. So it's good to know. And then that way people who are seeking out your services, they will also know that.
Yeah, thank you for that question. So what we're facing here when we talk about what happens after the split, what we're looking into, what are the kind of the measures of that success? Are we looking into what used to be called a rapid expansion, a MASP, which is like a slower expansion, the polycyclic turns? What are we looking into? What has to actually split, like ANS to PNS concept? What we're looking into the types of the expansion in terms of how face reacts to that. So these are multiple components to what the mid-palatal, mid-facial expansion can actually bring to the table. And now it's just my own case, and you can clearly see no filter, nothing, just how face has changed with over the year of treatment. And you can see that even my facial asymmetry has improved. What the specific notion I wanna touch on here is that midfacial expansion with either MARPE or FME, it might not necessarily improve the asymmetry. So it's not the basic goal of the midfacial expansion. What improves is that most of the times that asymmetry is caused by dental velar changes. And what we see that in 95% of cases, that asymmetry to the face is caused by the underlying dentition, the cant of the maxillary plane, the difference in the vertical kind of dimension of the alveolar processes of the maxillary arch. So this is what underlying structure makes the skin, which is like a curtain, which is like a drape, look like. And if you look at my face, you see that my nose is clearly canted. And the more I work with my gummy smile, asymmetrical gummy smile, the more I work with my maxillary cant, the more that nasal cant improves, and it keeps improving, and it keeps changing the kind of outline, the shaping of my both cheeks, moving my mandible where it should be. So I'm doing this with post-expansion intervention with my aligner
orthodontics.
component.
And how much expansion are we looking at between the photos? Like how much difference skeletal expansion?
So again, when I refer to expansion, it's usually, I never refer to the intermolar width, never ever. I never talk about that because for me, it's totally irrelevant when we talk about the expansion. I mean, it's less irrelevant with FME because we all know that FME does not affect tooth positions, even though what we start seeing is that after the FME actually splits, and that causes some degree of kind of molar drifting. This is what we've noticed, especially more of a like palate to buccal inclination with palatal cusps kind of dumping more. So that's the only components, even though FME has nothing to do, it has no anchoring kind of parts that lean against the teeth. We still see that the molars have a little bit degree of the drifting. But going back to your question, I had approximately 4.5 to 5 millimeters of expansion. Why I'm giving the range is because when we measure that expansion, we usually measure it at 3 points of the palate. So we measure it at the ANS level, we measure it at the kind of the middle of the palate, the middle third of the palate, and then at the PNS level. And with MARPE expanders, what we notice is that this expansion, even though it's considered to be parallel, the degree of that parallelism, it's 90%. So the ANS and PNS distraction do not necessarily equal each other. And we will see more of a distraction at the level of the ANS compared to the PNS, even though that PNS is almost 90% of that ANS. And what I'm showing here in this photo, you can see that kind of the second picture on the right side, it shows more of a retrusion to my mandible. But what we usually kind of perceive as a retrusion is the change in the head posture. So with the left side of the screen shows me before with more of a forward head posture, lifted chin, with head being postured more of a with extension, with a neck extension, while after expansion, the curve, the cervical curve has improved drastically with less of this cervical extension and with more of a parallel position of my, we call it Frankfurt horizontal, the plane that that kind of goes through these infraorbital and the acoustic meatus points. So kind of the head is being positioned more parallel relative to the actual horizontal plane compared to the other side. And what I've noticed is that once we see this change with the head posture, this is what contributes to the improvement with the under eye bags. So the more we tend to lift our heads and kind of compensate for this eye posture and parallelism, the more we engage those muscles of the under eye space, and the more kind of blood flow is engaged in this area. So once this head posture is improved, we have less engagement in this area. So the under eye bags tend to be way less pronounced, with less kind of darkness under the eyes. Is just the observation.
Yeah.
So just because we're paying a lot of attention to the aesthetic components, and when you have a female entering the office, females are mostly expecting some, I don't know, aesthetic benefits from this procedure, while males are coming with a lot more, I would say, the underlying medical problems. So we all know from our previous presentations that males are more prone to developing this sleep disorder breathing and the spectrum of obstructive sleep apnea. So in my practice, I would see more males who who approach us with upper airway restrictive syndrome or with the actually diagnosed obstructive sleep apnea. So we will be touching upon that as well. So now, when this split is actually out of question, what are we looking at in terms of the success? So by definition, split happens. So what is this successful expansion? So now we're looking into different aspects of success of this procedure. Now we're looking at the actual goals that we have kind of put in front of us before we started this treatment. Now the success will be way more or much more than just a simple split. We don't want to restrict ourselves with how far the appliance or the design of the appliance or the bone, resistance, they restrict us. We don't want to be restricted by those things. We want to plan on how many millimeters we actually want based on our goals, aesthetic goals, obstructive sleep apnea goals, overall like well-being goals, and posture goals, neck extension goals, things like that. So even though the success rate of the mid-palatal suture separation has gotten up significantly over the past 5 years, there are occasions where the surrounding sutures pose more than expected resistance. So we'll be talking about that a little bit later. And with a 3D guided mid-palatal piezocorticotomy, we have seen success rates approaching 100%. So that's why it's no longer a concern for me whether my patient splits or not. Even patients who have undergone first round of semi-successful, I would say, MARPE expansion, and then underwent bimaxillary surgery and are not still or yet satisfied with their results, we have a successful split within the expected amount of time. So for me, I do have a timeline when I know and I'm expecting that the split would happen. If it takes a little bit longer, then I would say there are other factors that are involved that kind of contribute to this time prolongation. And I have to kind of look closer into what is actually contributing to that. And I will be focusing on that today.
I do have a question about your 3D guided piezo corticotomy like cut. So is it something similar to like this, that you create 3D that has little puncture holes for you, that you plan with the CBCT scan, you plan where to do it, and then you do this little 3D printed thing, you pop it in the palette, and then that's how you do the piezo cuts? Is that correct?
Absolutely. So we plan for the degree, for the depth of those cuts. We plan for the actual positioning of that cuts, for the extension of those cuts. This is something that we have come up with just based on, I started with the non-guided piezocorticotomy, and I saw that this mid-palatal suture that we actually see, that is visible to us when we look in the patient's mouth, does not necessarily follow the actual kind of suture, the actual bone suture, the actual bone connection. So a lot of the times it might be dragged. And I started looking of what are the consequences of not kind of just eyeballing that. And I saw that most of the times what I see with those patients is that the nasal septum is left kind of bound to one of the sides of the nasal cavity, and then the other side is dragged, and I see this cut being a little bit asymmetrical. So I see one side expanded more than the other side, which is not what I want. So I came up with this procedure, and we filed for the patent for that, and so that is the invention directly related, and the extension and kind of the little things that contribute to that, the landmarks, the where you position those cuts. What are you expecting? It's not just the cuts where they go in the middle. So you want to have those cuts related to specific structures. So you have that nasal septum remain in the very middle. You don't want any of the sides to be dragged. You don't want any of the sides to be kind of dumping down and have come up with this. Result in a step after you do the separation. So all these things. Have to be kind of covered with this mid-palatal piezocorticotomy procedure.
Have other people yet adopted, because you invented it, I've read some of the papers that you shared of your reports, your case reports and your research in the Facebook group. And so it's strictly your invention. Do other providers, have they adopted it yet? Have you mentored anybody in that, or just strictly with your practice at the moment?
So in order to adopt that, it has to be, you cannot just adopt that. So it has to be done as this is a patented technology. So it has to be kind of done in a specific way. So we know that some providers, I saw that your group, one of the providers came up with this, but I don't know if they're doing the exact same thing. It looks kind of similar, and probably it's of great interest. So every time we publish a paper, and when to publish a paper, you have to go through several rounds of the review, and you get the comments from other providers, and these are the providers that have expertise in your field. So it's not just someone from, I don't know, other specialties. So every time I publish a paper, I get a lot of interest, and the reviewers ask for more details for the other providers to be able to adopt this technology. So this definitely poses a lot of, so there's absolutely, in what I see in our practice, there are a lot of benefits to what we do. And what we're planning on is to actually start teaching this technology to be able to spread it a little bit more, a little bit wider between the professionals, because there are a lot of benefits to the guided approach rather than just kind of visual landmarks when doing piezocorticotomy.
Yeah, that'd be awesome to see that in the future.
Absolutely. So now the question is just kind of going back to basics of what are the main reasons of why the midpalatal, like the basic split, fails. And what I'm showing you here, that this is the MARPE, and we know that once we kind of start with the MARPE, some MARPEs, they split, and even with females who we know are of a less concern compared to males, even in females, MARPE can fail. And one of the reasons for that is when the specific design, this specific screw bends within itself. So it has the power screw, the tiger screw has two parts, two similar components to that expand while we're doing that kind of unlock and unscrew while we're doing this expansion. So at some point when the pressure, the resistance of the sutures, it goes over what the actual position of the screw is, so it causes some bending. So most of the times the sutures, the maxillary zygomatic sutures contribute to that, and pterygomaxillary sutures to that. So if you look at I don't know if you can see that, if you can see my mouse over here. So if you look at the screw, you can clearly see that one of the parts is clearly bent relative to the second half of it. And that's why at some point, even though we saw a little split right here, so that appliance doesn't go beyond what has already happened. So it may split, but it may not go beyond, I don't know, maybe 2.5, 3 millimeters of expansion. So that is one of the reasons why the expander may fail. So for that, to avoid that, it has to be a specific design of the framework and a specific position of the screw, this actual component, like the jack screw, that would prevent this from happening. So we want this to be kind of supported on both sides, both posteriorly and anteriorly, to have the rigid framework that prevents this jack screw from bending. Another reason of the appliance, any sort of appliance, even with the FME, this could happen. So, especially with the anterior screws that are really, really long screws that we want to engage the thickest bone that is anteriorly. One of the screws, just because of its length and its flexibility, it can have a little bit of a bending to that. So that can engage and kind of impinge into the nasal septum, even at the maxillary crest. So if you're seeing my screen and if you see those two mini screws, the nasal septum is supported by a thicker bone, which is the bone which is called the maxillary crest. So these screws, this is just like an exaggeration. It doesn't happen in real life, but the length of the screws is not that far into the nasal cavity. Usually it's under a millimeter, like 0.5 or a millimeter, not this much. But just to make a point here, if the mini screw kind of engages into this maxillary crest, like the thick bone that is located very close to the nasal septum, then it cannot support this maxillary expansion and maxillary kind of dragging of those two halves sideways, because that maxillary crest is a part of the nasal septum, like the bony part of the
So it's like an anchor, you're saying. It's like
exactly, yeah,
strong.
exactly. So that was a case years ago, when Dr. Von Moon came up with the MSE, and when the MSE was positioned kind of based on the visual landmarks of the palate, when the CBCT was not that widely used to plan those cases. And with the kids, or with growing kids and adolescents, it was not the case, because everything was so soft and nice that every single patient expanded. But once this technology has started being adopted for adult patients, this is a different story. So now, at that point, we started kind of looking and paying more attention to the maturity of the suture and to the actual location of the screws. And then at that point, MSC has started being kind of planned with the CBCT more often than it used to be, right? So just to eliminate this sort of kind of design fallacy. Now, so again, this is just the same picture of the MSC that it used to be, and the conventional MSC was more of a prefabricated appliance that had to be adopted along the alveolar ridges and with the traditional bands, and it has the predetermined width and kind of length and the dimensions to this appliance. So you can only locate it or position this appliance in a very specific area. And if that area is a little bit thin in terms of the bone thickness, or if it has some distortions to the location of this midpalatal line, kind of visually separating the two halves, then you would fall into some sort of challenge, because one of the screws may definitely impinge on that maxillary crest. And if you just eyeball this, so this is the left side is the picture of the patient post MSE, and this is an adult patient in early 20s, a female. So we were able to split her by 3 millimeters. And if you look here, it looks like it's almost perfectly symmetrical against this midpalatal suture, but it's not quite perfect. So the previously positioned appliances were mostly they relied a lot on the visual landmarks rather than on the actual position of the nasal septum and the maxillary crest, which is something that can prevent from further opening. So with that type of appliances and with that type of planning and positioning, we used to be limited on how far we can expand those patients. Even though the appliance was planned for 10 or 12 millimeters of expansion, we could only expand by 3 millimeters, maybe 3.5, not more than that, just because of that impingement and the kind of planning part of it. So now, kind of again to illustrate the same concept of the nasal septum. If you look at the CBCT, so what you're seeing on the top is the kind of the frontal view of the patient. With this is the brain, these are the eye sockets, this is the nasal cavity, and if you look here, so that is the patient of post. This is MARPE patient and post MARPE separation, and if you look, this separation here in kind of darker gray shade is the perfect location of the split. And you can see that the split is right below the nasal septum. This is what we do with the guided piezocorticotomy. This is what we want to see with the guided piezocorticotomy, the perfectly symmetrical split here. The other part of it is how we achieve that. If you look at the nasal septum, it's not quite straight, right? So there is a little bit of degree of an arc to the nasal septum. So that is the big part of what we plan here, is to make sure that we follow that. And we do not strictly rely on the visual landmarks that are seen just by looking at the roof of the mouth. So now this is a patient, and again, the positioning of the appliance. This is the patient that was treated with FME. You can see, so you can also see that this split, again, if FME was combined with piezocorticotomy, and regardless of the appliance, whether this is MSE, MARPE, custom MARPE, any sort of device FME, I will always use this 3D guided piezocorticotomy design, and I will also call this MARPE F.A.C.E. just because this is the protocol and the sequence of what we do, not necessarily the design of the appliance or the specific appliance that we're using. So the MARPE F.A.C.E. protocol, it applies to all sorts and all designs of the midfacial expanders that are available out there. And we know that our European colleagues, they rely a lot on the kind of two-stage positioning for their MARPEs and the benefit system and different designs that position their TADs first and then take another scan, and the superstructure is kind of based on the scan that was made with the previously positioned TADs. So there are different approaches. In the United States, we rely more on a kind of one-step approach, and with the kind of direct positioning where the appliance framework is the guide in itself, and with FME as well. So with FME, it's a little bit different when we have several kind of guides that are, this is more of an indirect approach, but again, it's one-step approach. And so the appliance, the framework kind of guides those TADs on the way they have to be positioned. So what I'm seeing here is that, what I want to show here is that there is one little tricky thing, which is called the transverse suture. And I pointed that out in one of the recent publications. And this transverse suture is located in the very back of the palate, in the distal third of it. And what I've seen very beneficial is when the FME, especially with the latest design and with 10 screws, when you can actually kind of extend and position that FME with one or two pairs of screws kind of slightly beyond this transverse suture to kind of cross it so that the split engages this posterior part of the palate. Why this matters? Because this transverse suture, it cuts the palate into two halves. We have the two anterior thirds, which is the part of the maxillary bone, and we have the distal third, which is the palatine bone, which is the completely separate bone. And the palatine bone has a close relationship to the sphenoid bone, so it kind of touches, and it has those sutures with this sphenoid bone, which is the base of the skull. So, in my experience, and what we spoke about with Joe Hacks on our recent podcast, for me, it's crucial to engage that horizontal part of the palatine bone, to have the split extend all the way to the PNS, to have the impact on the size and the dimensions of the nasopharyngeal airway. So that's why with FME design, it's important to extend those mini screws beyond that transverse suture, and the same with the MARPE. And in both approaches, to extend the piezocorticotomy cut all the way to the back, to the PNS. This is something you cannot eyeball because you're kind of afraid of just impinging on the soft palate or going too far. So the piezocorticotomy guide allows you to do that and to safely extend it to where it belongs. So here again, this is what I touched upon is the design.
We're not doing any cutting in that perpendicular area, right? You're still just cutting straight down the midpalatal suture. Or are you saying you also do cut that suture?
I always do that. I always cut all the way to the back.
So you're doing like a cross cut? Or are you saying we're just like?
I'm saying that I'm cutting across the midpalatal suture. We don't need to, we want to preserve the transverse suture. So we don't want any fractures in the midpalatal, in the transverse suture, because if we have fractures, and which used to happen in the past, if you have that fracture, there's a very high probability of one of the segments of the anterior segments to kind of drag forward and to create this asymmetrical anterior posterior expansion, rather than kind of so having this movement of one of the segments in several planes of space, not only transversely, not only sideways, but also forward. So what we see, so this just kind of moving on with this with the sutures that contribute to the most resistance is always zygomatic and maxillary sutures, and I would say in males is the main source of resistance, and it's also the pterygomaxillary suture. So the successful expansion is when, again, in my in my approach would be something that allows for the pterygomaxillary suture separation. This is what we want to achieve because we all are looking into having this nice and forward movement. This is one of the biggest things. And there is no forward movement without the separation of those pterygomaxillary sutures. So forward movement in the past was achieved through drifting of the molars with the framework and with inclination of the incisors and molars, but not with the actual separation of the sutures. And this is what was achieved with the kind of hybrid appliance designs and with the face mask attached to the Hyrex appliances. But again, it's not the case now with the FMEs and with MARPEs where we get a lot of forward movement just because of the expansion itself. So when I refer to the forward movement and when we're looking at the pterygomaxillary sutures, this is where we're looking at. We all know that some approaches with SARPE, which is the surgically assisted rapid palatal expansion, the SARPE kind of implies that the pterygomaxillary suture has to be separated surgically. With the midfacial approach, and we know that SARPE manipulates with the maxillary bone at this lower level, kind of subnasal to the so that part that is below the subnasal, kind of below the nasal cavity. Even though we
SARPE here, right? Like the Lefort type cuts, you're saying? Is that what you mean?
Exactly. Yeah. So the floor 1 is something that manipulates below the or within this plane of the nasal base, while MARPE and FME, that's the movements here. They relate to more of a skeletal or Lefort 3 type of movements. So these are the different sutures are engaged. So we have different types of movements, different rotations of that midfacial complex. And with SARPE, previous, just like we discussed with you in the group on Facebook. So you asked me that with SARPE, what are the predictors, or with the MARPE, what are the predictors of having that downward rotation, right? I was saying that it used to be that age was related and that SARPE produces purely downward rotation. It used to be just because SARPE manipulates within the different sutures, within the different levels of the maxilla. And now what we've seen with our research that we conduct with different appliances and different patient groups within like the adult population here that we see in the practice is that MARPE actually produces to some degree a counterclockwise rotation. And it's a completely different notion. It's a completely different kind of counterintuitive or counter what we're used to see. But it's actually what we see a lot when we do the 3D superimpositions and 3D analysis, that the mid-palatal, that the palatal plane or the ANS-PNS plane, it actually rotates around the center of resistance of the maxilla. So I do see counterclockwise rotation of the maxillary plane way more often than I do see the downward rotation. And one of the very kind of recent observation is that patients who come with the pre-existing downward rotation, they might have the downward rotation kind of preserved within their face, but that downward rotation can actually rotate counterclockwise under certain circumstances. So it's not necessarily that every single patient who undergoes this procedure will end up with the downward rotation. No, it's not the case.
Are there ways to ensure, because you said in certain circumstances, and I am one of the ones who had downward rotation and got a gummy smile with MSE, and so I'm curious because that is one of the things that I'm alert to that can happen with another expansion. So yeah, like what would those special circumstances be? Does it have to do with the shape of the palate? Like how do you know, or do you know?
So that will be the topic of our next
Okay.
meeting. That's a completely different topic. There's a lot of components that we have to really dive into because again, this notion of the downward rotation, it's pretty much misunderstood and confused with other components that contribute to what we see with the gummy smile and all other factors, and with the mechanics that is used kind of post expansion. So that has to be addressed, and it's really it cannot be explained in just one sentence or in yes or no, or just outlining the factors. It will be a topic of a separate conversation here.
Okay, fair enough.
Yeah. So with the separation, what we want to see with the NS to PNS, and here what we see is the MARPE separation. And if you look at that, it will be the red, the yellow, and the green. So you will see that the kind of NS or around NS, like proximity separation, would be slightly wider than that at the PNS level, even though we have a very nice PNS separation here. But it will be slightly kind of this proportion, the 90% proportion of PNS separation to NS separation. So, but that is still considered to be a parallel expansion. And what we want to see is that the PNS actually separates, because it used to be, again, this notion of the MARPEs and hybrid MARPEs and the previous approach with the Hyrex appliances that used to be a V-shaped separation, while the V-shape kind of ended up here. You can see the transverse suture, right? So the V-shape,
Yeah, I can.
yeah, you can this like a very subtle line here, and it's always like a heart shape. It usually extends something like that, like in a heart shape fashion. So the V-shaped separation used to be something that kind of ended up here, and nothing happened to the back of the palate, to this horizontal plate. So what we want to see is that what we usually see with FMEs, this is a great plus of FME, is that we see this nice and predictable separation here at the area of the horizontal plate. So that's a really cool thing about FMEs.
And you're saying that's basically because it's such a long box, rectangular box, that some of the screws extend actually into that section.
I would say so. Yeah, this is one of them, my preliminary conclusions. And also when you look at the case that I kind of used for my presentation with the jaw hacks, I have this FME appliance positioned in reverse. So kind of the posterior part is facing the front teeth and the opposite. So what I had to reposition this appliance 2 times because I didn't like the way it fitted, and I used the same guide. So what I figured is that the design is actually really cool in terms of that you can use this posterior box to kind of tunnel the position of those screws. Namely, the anterior screws of the FME are really tricky because they're so long and they're kind of more prone to bending. So to engage that anterior bone, you have to use 18, 21 millimeter screws, and they're really prone to bending just because of the length and the material and the diameter. So if you have more of like a tunnel shape box that you insert those screws in, something that I'm used to with them with custom MARPEs, you have more control over how these screws are kind of guided into the bone, and you have less chance of bending and kind of dislodgement and things like that. And also what I figured, just by kind of playing with the FME design, it's a really cool thing, is that you could play, just because these anterior screws are slightly more apart than the back, just because they're not a part of the box. So they're kind of a little bit separated from them. So you can achieve proportionally wider expansion in the back than you would get if you don't do that. So these are just little things. And I know we're in this gray area where we're exploring this, and just the more you do of those cases, you see what can be potentially improved with the design of the appliances and how you effectively use. So that patient, when we repositioned that appliance upside down, that patient separated within 5 days, like under 10 days. I was like, wow. That was super fast, even for the FME, even with the conventional kind of activation protocol. So that was like a really eye-opening for me. So now, again, just going back to those pterygomaxillary sutures, which are of the utmost importance here. And if you look, it's just where they're positioned. So I borrowed this very nice picture from one of the articles on the pterygomaxillary junction here. It's just this by chin and lino. So this is where the pterygomaxillary sutures are positioned. So what we see, and you can clearly see that there are several kind of lines. Here is this the actual mid-palatal suture line, and then it extends all the way to the PNS, and then you have this horizontal line, which is the transverse suture, right? So this part is very closely related to the position and the location of the pterygomaxillary sutures. And if you put more pressure, and if you kind of force those two halves sideways, you have more chance to separate the pterygomaxillary suture. It is just very close, and it's in high proximity here. Again, this is just an illustration of that guide and how we use it and how the actual kind of cuts are positioned relative to the nasal septum and to the two halves of the jaw. And what we usually refer and what patients kind of tend to notice a lot. So saying, hey, I'm just looking at my palate. It looks really asymmetrical. A lot of asymmetry when you just kind of look at the palate from upside down or like from just kind of looking at yourself in the mirror. It comes from the bending of those alveolar processes. So most of the times, one of the alveoli, like one of the vertical sides of the maxilla, is bent or kind of tilted or kind of inclined sideways more than the other. So this side, where with more inclination, will look wider, while it's not the case. We are not supposed to look at the teeth. We're supposed to look at the base of the nose, and this is where I'm kind of moving to. And just to kind of briefly mention, the MARPE F.A.C.E protocol is about 24 months, and we kind of achieved that expansion within the 3 months of expansion, and with no adverse effects, with no adverse events of like fractures or anything like that. Very nice and very physiological expansion with kind of gradual force decrease and gradual frequency decrease. And of course, no retraction mechanics at any point of it. So again, just to point here, the sutures that present the most challenge here is the zygomatic maxillary sutures right here, and the pterygomaxillary sutures that we just saw on one of the previous slides. So this is where we measure the nasal base. So one of the questions I very often see on your group that patients keep asking is where we measure what we actually measure, how we measure this nasal base. And this is what I measure. I never measure the intermolar width. I measure the nasal base. And there are specific guidelines of what I want to see. And again, this is just before FME, and we see that nasal base has different width at different levels. What we used to see a lot is that the slices that we see in articles and the literature are the slices usually at the level of the first molars. This is where we used to measure it, just because it all comes from kind of approach of the front anterior posterior cephs, right? So the anterior posterior cephs are the superimposition of multiple layers of the CBCT and kind of with a 2D picture. So we would see the widest area, and we would see the first molars being in the focus of this image, and we would measure the first molars. But with the with the luxury of having the CBCT, you can actually scroll through the slices. And what I would be looking for, I would be looking at the point of the least width. And for me, why that matters, is that this least width is where the nasal passages or where the nasal airflow has the most resistance, right? So where we have the most turbulence. And when we think of the kind of nasal airflow following this Poisson rule, it relates to the diameter, to the smallest diameter. So the kind of the velocity of the airflow depends on the diameter of the tube, but it's not the way it actually works. We see that we have a lot of points where the turbulence can can be enhanced, and especially with the turbinates and with the curvature of the nasal septum. So it's not quite the case. So that's why the points of limitation, the points of the most restriction, are the narrowest part of the nasal passages here. And I would be looking at the narrowest width of the nasal passage, and I would be kind of referring to the widest part of the nasal passages. So for me, if I'm looking at this patient, I would be seeing the narrowest at 27 millimeters approximately, with the width of the lateral walls at 37, and I would be seeing the 35 as the widest available. And usually that uh, widest area is the area that is very close to the PNS. So we will have the widest kind of base of the nose, closer to the transition between the nasal passages and the nasopharynx.
So are you
now,
saying these are the only measurements you take now? Like you don't do anything like within the teeth area? So not even true intramolar, like in between the roots at all?
no, I'm
So
not
just
measuring.
okay, so just these are the measurements.
These are not the only measurements, but in terms of the position, in terms of the base of the maxillary bone, we take a lot of measurements, and that is a part of kind of, again, wider topic here. And we will be again publishing research on that, on what specific measurements we're doing. But if I would measure the anything related to the maxillary base and the nasal base and the different dimensions, I would not be measuring any of the maxillary, kind of the interroot distance. Why? Because these measurements are very highly variable, and they can be altered with my tooth movement techniques, and they will be changing because they, and especially with the MARPE F.A.C.E, where I do a lot of anterior posterior movements to the teeth, specifically anterior movements. I will not be, so the point where where that tooth was at the beginning of the measurements, it would be different from where it ended up later. So we will be referring to different kind of cross sections of the same, in the same projection.
Yeah, it's really smart because with my intramolar width has been all over the place, but I appeared to have gotten a lot of expansion with my MSE. But then after Dr. Ting did that thing where he brought everything back in, I lost the majority of it. And so it would be very interesting to actually just be measuring, the nasal aperture to see the changes, because we know that, anything with arms, like you said in Jaw Hacks last podcast with you, like you get a 30% teeth tipping. So yeah, I mean, my IMW went up and then it went back down. So this is actually pretty wise.
So, and again, with the intermolar width, you're operating within like 10 millimeters or 12 millimeters. So you're operating with kind of impressive numbers, while the actual numbers we're dealing with are way less than that. So if we measure that intermolar width, it will come up to 10 or 12 in increase. But if you measure the actual nasal base width, it will be way less, but it will create a huge difference. So now, and this is what we're actually measuring. So now let's just go back. So we had 35.4 with FME before, and that was the widest. And then we had 27 of the narrowest, and now we ended up with the 32.99, almost 33 with the narrowest. And you see where the nasal septum and the kind of the split are perfectly aligned along the midline. This is what I want to see. I don't want to have my nasal septum be dragged anywhere. I don't want to have any of the sides to be dragged anywhere. So it ended up in a really nice expansion here, and we see that 37.9 at the back of the palate. And we know that even with the FME, it is still PNS as the level of the most kind of resistance, just because of pterygomaxillary sutures, but we still have an impressive increase in that nasal base width. And this is what we really want to see here with our midfacial expansion. We want to see the bone movement. We don't want to see any tooth movements. Tooth movements are unlikely, unwanted. We want to have those teeth upright, straight relative to the base of the bone, right? To have those forces kind of going through the axis of a tooth, rather than ending up with the impressive intermolar width and the teeth tilted relative to their kind of vertical axis. So again, just going back to the facial changes, this is one of the cases that the picture from one of the most recent articles, and we see that first of all, what I want to kind of drag your attention to is that we see a massive change in the patient posture, and you see that the ANS. That the ANS PNS was kind of rotated upward, and even though these um, two skulls are aligned and positioned relative to the same coordinate system, like XY axis. So it's not that one skull is with a forward head posture, another with a different posture. No, they have the same XY axis coordinates. So what we're seeing here is that ENS it was a little bit kind of more kind of tilted up, but it remained within the same coordinate system. I mean, it remained within the same positioning because the head changed it. The changed it not the curvature, but the neck changed it in the curvature. So if you're looking at the airway, this airway is more curved because the head and the neck have to do a lot of compensation here, while this airway is more straight, and the airway would follow the curvature of the neck. With this neck curvature, we would see a lot of compensation in a different curvature in a different direction. So what if again your audience in the face group book, whoever asks about, do you see any neck changes? Yes, you do see neck changes almost immediately, especially in class 3 patients. You see almost immediate changes within the 2 to 3 months of the intervention of the expansion, and you don't need a chiropractor for that. So that happens just automatically because body senses the change in the size of the airway and doesn't need to compensate that much as it used to with the posturing of the head and neck. And now it's the FME patient, and you see that the labial mental folds have become less deep. We do see that the cheekbones have come up further forward. We do see that the nasal kind of outline, the skin outline has changed. But again, I want to specifically emphasize here that skin changes widely and to a great extent depend on the bone changes. And you cannot just judge the results of expansion immediately after expansion, because you have the system completely undone, right? You want to bring those teeth in the positions that they belong, and you have your maxilla wider than the mandible. So that tissue, the skin, is dragged by the position of the mandible and the bite, and everything is kind of unbalanced. So your nose will go back to normal once the bite is normal. And this is what is the kind of post-expansion part of the procedure. And now you can clearly see that before procedure, the position it's the kind of the grayish, and that after procedure, the bottom jaw, after we do the expansion and when we go forward, the bottom jaw wants to lean forward. It wants to kind of catch up with the position of the top because top moves forward as well. Top becomes wider. It creates a wider range of motion, wider diameter, and the bottom feels this freedom and wants to slide forward as well. This is the patient that we did 10 millimeters of bone separation, and you can clearly see the kind of the fullness in the face. And again, this is just so the left side, the gray part is the after expansion. The kind of the pink or beige part is on the before expansion. You see that the structure is being enhanced, even though we see like a post expansion, a little bit of a inflammatory puffiness. But but you can clearly see the difference between two. And again, here we do have gray representing the after, and the kind of beige representing, or peach, I don't know, representing the before. And you see that the mandible has kind of slided forward to maintain that contact between the front teeth, top and bottom.
That's the whole nose changing thing is probably one of the other top questions I get asked in the Facebook group. And people are very concerned about it. But I find I've never really seen anybody who has got an expansion and then their nose widened very slightly and it looks bad. Like I find that it's usually, if it happens, it's so subtle most people don't notice, but it also needs to change to stay balanced with the rest of the face. And it generally, in my opinion, balances the rest of the face out. But again, like I know that's a big concern for people. So I
Concern-free extension, right? Concern to kind of have some unwanted changes. And you, and you are a woman, and you pay a lot of attention to detail. That's why when we look at the face, and you've noticed that. So I'm in total agreement with you. What you're saying is that when you have this post-expansion, post-treatment overall picture of the face, it looks very well balanced because everything came up forward, and you really need this kind of enhancement with little tiny, like half a millimeter of a millimeter of a subtle expansion within the skin, right, with the skin outline. So it looks really, really nice and balanced. So you can expand at any age. There is no limitation, nothing. We are not limited by, I don't know, our age group, our bone thickness, the maturation of the palatal mid-palatal suture. These are not the limitations. And again, just to show the changes after the 10 millimeter of expansion, you can clearly see the left side where the drastic neck extension, the patient is trying to maintain nice and wide size of the airway with the forward head posture, right? With the kind of lifting the chin and the overall head. While here, this is what I notice a lot of times when we have this nice expansion, the head posture changes and it just balances out and just kind of relaxes, and we don't need to extend our necks that much. And you can clearly see this huge airway on the right side.
Yeah, it just
Just,
looks so much more comfortable too. Like
yeah,
just looking at the difference between the two, like it looks relaxed, the
it
right after
does.
photo.
Yeah. So this is just a couple more slides, and here this patient came with the Invisalign and attachments before, and this is how we expanded this patient. So we use some temporary composite bondings just to close the gaps for patients who ask for that, and we're using shape memory aligners. You see all the attachments are gone. We're not using the attachments, but maybe rarely or sometimes when I forget to remove the attachments. So these are just the clear aligners that are directly printed, and this is the part of our protocol. So this is where we ended up. We removed that composite completely, and this is one of the and this is the just a year into treatment changes with the repositioning of the teeth with just clear aligners with no attachments and nothing on your teeth, just aligners here. And this is how, so this patient has kindly allowed us to show her pictures of the face, and you can see how the face changed. And it's just like, it's just way fuller, well, healthier, looks so much better with the fuller smile and with the cheekbones and the profile overall. And I just love the changes for females that we have, and males and everyone.
Yeah, I agree. I personally usually really like the changes that I see. Something you said in the Jaw Hacks podcast was that what I found really interesting was that for women, it's the maxilla that really enhances the aesthetics, and then for males, a lot of it is the mandible. And I never thought about it like that, but it makes a lot of sense. Not saying that the maxilla or the cheekbone changes don't also help male aesthetics, but to break it down like that was a little eye opening.
It just makes it just makes this mandibular I don't know, type of masculine face. We want to see this nice jawline in males, and we don't want to see this in females, right? We want to see more of like a fragile or petite picture of the face, of the female face. And this is especially something that has brought into our culture with K-pop, right? So
Yeah.
this, yeah. Yeah, and this is one of this is just a part of our culture nowadays. And what we see a lot of kind of cheek hollowing with this while we're in treatment. And this is again what we see a lot with our Hollywood stars, that everybody's just eliminating their cheekbone, like the fat here in this area, and this is what we naturally get with the MARPE F.A.C.E. and with the mid facial expansion.
Yeah, so instead of removing your buccal fat, you can instead just expand,
Yeah.
and affect the cheekbones, and then you'll naturally get that shadowing, that nice hollowness. I just love that you pay attention to aesthetics, as people who have if anybody's been around, like, the orthodontic community, have gotten consultations from a few different people, you'll know that not everybody focuses on the whole face, and it is very much true, right, that the bony structures influence, like, what appears on the skin, and so it's just nice to have providers who are that attentive. Before we get in the Q&A, I wanted to touch on one thing that you posted on Instagram, and I got the most, like, direct messages about it, people asking me, like, "What does this mean? What does this mean?" was when you
I
posted
know what
about
you're talking about.
yeah, I know that you're gonna know, is you
Yes.
had made a comment that you would potentially do another MARPE in 5 to 7 years for anti-aging benefits. Now, of course, I have my theories as to, like, why you said that, and that's what I shared with people who messaged me, but I would love to know straight from the horse's mouth what you mean by that.
Yeah, absolutely. Yeah.
Yeah.
So one of the comments and like one of the immediate comments were when I posted. So I posted it twice actually. I posted it maybe like a year ago, and then I posted it once again, just by looking at how my face changes and looking into this whole transformation. I'm seeing that I got a lot of facelift. I got a lot of enhancement to my cheekbones. And again, just going back to those comments, um, I mean, patients or like just like the community started commenting, saying, "Hey, does it mean that it's kind of bounces back, or does it mean that it relapses, or it's not a stable outcome?" No, this is not what I'm referring to. It's an official answer. So the official comment on that is that I see such a huge improvement in my facial shape and the way the skin looks and glows, is that it's just, in my opinion, it would be a part of the I say rejuvenation protocols as as we move on, as we make those protocols more efficient, kind of less time consuming, more efficacious in terms of how fast we can achieve these or these things. And when we focus on what can be achieved with what specific tooth movements or movements around the face, I would say that with all that experience that we particularly focus on here in my practice, we would come up with less time consuming protocol to achieve this facelift. So when I'm asked if I have fillers, I have zero fillers in my face, and it's just all natural. And I got this nice cheekbone popping effect with the MARPE face and with expansion. And again, just a little observation here is that the degree of expansion matters. You cannot achieve the same result with different degrees of expansion. You cannot achieve the same results with kind of underexpanded. So there is like this golden ratio, or like the perfect number where you want to go to achieve certain results.
And then so for aging, I know that our bones, what's the word? Like reabsorb, what's the word I'm looking for? Essentially, like, we have bone loss, right? And it affects our teeth, our facial structure. We get fat loss, or muscle wasting, and then bone loss. So I was theorizing that, like, as we continue to age, with the bone loss, it would be a way to, like, circumvent that or work against it, and then, like, keep the structures, high, and, like you said, give the facelift. Does that have any truth to it as well?
So we don't have any, and I'm a research lady, so I want to dig into research and have the evidence right from the literature. So I haven't seen a lot to that, especially like an aesthetic oriented literature here. But I believe that this 5-7 year kind of time frame is not enough to have the actual kind of aging effects in terms of the bone volume and things like that. So we would rather compare, I don't know, 20-year or 30-year interval to see the actual drastic change between the bone volume then and now, right? So I would say 5-7 is less. So it's more of like a skin stretching, skin rejuvenating. So more of a kind of superficial effect in terms of, you want to pop that bone, you want to grow the underlying bone. What happens here? If you expand, you create spaces that your body fills in with the new bone. So we're actually growing new bone in between those the existing bones. So we're just adding that, and we're adding it naturally.
Yeah, so why not just do it in one round? I think that's where the confusion is why a second round, and then like how many, I guess it doesn't matter saying how many millimeters, but like how far would you expand a second time for these results? Is there a reason you didn't do it for like just one round and done?
So if you do too much, you end up having more. Again, it's the area, it's the gray area yet. That's why it's not that widely adopted idea. Just because very few providers kind of focus on that and see the actual benefits in that. Uh, but what my notions here is that a certain degree of expansion, certain degree, what we're measuring is the degree of the amount of midfacial separation, mid-palatal separation, right? So with the mid-palatal separation, you will have your bones moving to a certain degree in different directions in a more of a forward outward direction within the other bones, like the cheekbones, etc. So what I'm saying is that as the skin ages and as we have less underlying and thickness to the skin, right, and the underlying layers, this subcutaneous layer, the soft tissue, the connective tissue layers, we want to kind of reimburse that evening with more of the bone structure. But
Just a
again,
little booster.
yes,
Got
exactly.
it.
Mhm.
All right, sweet. Well, let's move on to the Q&A. We've got some questions from the audience. So first one is, do women with FME TENTAD require piezocorticotomy for palatine bone split?
Do that.
Sounds like it doesn't necessarily require, but that's just the insurance, right? That like you as a provider and other providers take to just do it. Because we were saying women are known to be easier.
Easier, but we don't know the actual pattern of how this happens, right? So that may just end up at the border at the transverse suture. It may go into the transverse suture to some degree, but we don't want the actual. So it depends, and I believe again to come up with certain guidelines and conclusions, you have to have a really good number of the cases and to analyze those cases. And what I'm referring to as of now is my clinical observations. And just because we do these procedures uh, almost every single day, and we have a lot of kind of material to superimpose and to analyze. So we analyze every single case and we look into why this happened, why that doesn't happen. But to come up with certain conclusions, we have to have a way bigger number to actually come up with that. So again, my rule here in my practice is that I don't want to play around with the nasal septum. The nasal septum has this bony component closer to the back of the palate, so that nasal septum is not completely a bone. Nasal septum is attached to this maxillary crest if we're looking just at the face. So the maxillary crests are located at the base of the nasal septum. But part of the nasal septum is a cartilage. Part is a little bone, is a vomer. Part of it is this vertical part of the palatine bone. So we have different components to that, and we don't want to play with how it separates and where it separates. We want to make sure that it separates the way we want it, and in a nice and symmetrical fashion.
Yeah. Yeah, I'm with you. I know there are a lot of providers out there who are guaranteeing splits without it. But I don't know. I'm with you. So, number 2, does the previous orthodontic work limit the amount of expansion one could get to ensure tooth stability?
We want to avoid any like the aggravation of any existing recessions, any pre-existing bone loss, especially on those buccal surfaces. And if there was any previous dental work or orthodontic work done, if that relates to the previously done dental velar expansion, then I would say there would be a different appliance design, and I would rather go with FME than MARPE just to avoid this excessive tooth tilting. And I would, again, if that is MARPE, then I would be playing with the appliance design. And if this is a female, I would rather remove those arms almost immediately, or just put some arms that would be more so for the framework orientation rather than to lean against the teeth. So there are multiple factors related to that. But overall, if there was any previous orthodontic work done, and if there are no contraindications in terms of periodontal health or anything else, then we're good to go. We can go with expansion.
Cool. So as long as the healthy teeth and gums and structure is there, then there are no limits. Got
Yes.
it.
Yeah.
Next question. If there's an asymmetric stretch or potential break at the frontonasal suture with asymmetric expansion and you back turn and give it a year to harden, would you recommend trying again with a second expander?
That's a very specific question. Mm, I
Well, do
would,
you need to wait like a year? Like let's start with
I
how
would say
long do you need to wait if
I
you
would
end up having to reorient an expander?
So again, just if we extrapolate this data on the maturation of the midpalatal suture, which is different from any other suture, just because the composition of bone is different. So in maxillary suture, that was frontomaxillary suture or frontotemporal suture?
Frontonasal suture is what they
Oh,
said.
frontomaxillary suture. Oh, so I don't know if this is a misconception or if this is just so frontonasal suture can fracture, and it's not a fracture, it's the separation. Just because it's a suture, it's supposed to separate. I would say that there is no such a thing as the fracture of a suture by definition, because this is a suture.
Oh, because they're like already basically fractured forever. They're already
It's
split.
not fractured. It's just because this is where the bones come together, and it's
Joint.
supposed, yeah. And
Right.
if you talk to a chiropractor, they would say that the sutures are constantly mobile structures, and they change, and they are moving all the time. So they do not fuse permanently, right? So it's not supposed to be a fracture just by definition.
They're
And
talking about, they just clarified the question. They're talking about up here. This one, I think. They said suture at top of nose.
um so what we have several sutures in that area.
But same thing, right? The same concept applies that it's
Yeah.
essentially it's a joint. Yeah.
Yeah, so we have several things that let me just do this. You don't have my presentation anymore, right? Yeah. So we have front and nasal. So we have two nasal bones here. We have a frontal bone here. We
Yeah,
have maxillary
put
bone
this
here. We
little
have
guy, right.
maxillary bone. Yes. One, two, three, four, five sutures in there. Yeah.
You got yours?
Yeah, that's mine.
Perfect.
So we have one suture in between. This is one. This is in the very middle. We have one suture here, which is frontomaxillary. We have frontonasal. We have frontonasal, frontomaxillary. So we have five sutures. What splits is usually this, like the horizontal one.
Top one, okay.
Also, what can split is this one, like
Along the
the
side.
nasal bone, and this one in the middle very rarely splits.
And
Almost.
are any of these ones you don't want to have split, or which ones are common and which ones are you don't want?
This is the most common. I don't want one side to split and the other one doesn't.
But if both sides split, is that all
That's
right? Okay.
That's fine. It will. So you don't need. You're not limited to. You could wait for a year, but again, my understanding and my experience says that once it's split, there was this excessive resistance or limitation or underdevelopment in this particular area that forced this particular suture to split. So kind of to reinvent this balance within the skull. So none of the skulls ever is symmetrical, ever, never, ever. And the more we do those CBCTs, like our CBCTs that allows us to see even the back, like the occipital bone, like the very back of the skull here, even this part. So most of the time, if you look, I don't know if you can see that. So this is like the view from the top. So most of the times, one side would be flatter than the other. Not
Yeah,
just
mine are a little cockeyed. I've always noticed that when we're going over my CBCT scans.
so
Yeah,
it kind of releases those sutures. It kind of lets it go.
gotcha. So are you saying though, like, say that somebody fractured it only one side and then they're trying to let it heal. Are you saying that if they were to let it heal for a year and come back, there's a big potential that it would just happen again? Come back to expansion, I mean.
So there's again that there's one more thing here. If you have one of the sides split, your bite is a very big thing that stabilizes the rest of the bone movement and the kind of the dropping of that part of the bone, right? So if your bite is off and if there is a symmetry to your bite, if there's nothing done to the bite to kind of maintain this nice contact, to balance out the forces coming from the masseters, temporalis, all the muscles of the like the chewing muscles, you will not have, so this part or this side will continue dropping because there's nothing that counteracts that. There's nothing that resists that. What resists this asymmetrical splits is the bite. So the main point of having a nice orthodontic post-expansion treatment is to maintain a nice stable bite that would not exaggerate that asymmetry. You want to have a nice parallel occlusal plane and the maxillary vertical kind of delta alveolar processes nice and equal and symmetrical here. You don't want one side to be shorter and the other one to be longer. So this kind of the dropping that promotes the further suture separation and asymmetric, I would say, healing.
So if this happened to somebody, ideally, then if they're trying to wait for another expansion, would they want to then work on stabilizing the bite in this time? Is that kind of what you're saying?
So if you decided to just kind of, if you had this expansion and you dropped it somewhere in the middle of the expansion or right after expansion, I would seek some sort of stabilization or not go too crazy with expansion, kind of to limit the amount of expansion and not to be scared with this separation at all, just because the separation itself is not a problem. It's not an issue. It's the part of the balancing out of all the pressures and all the forces within the skull. It's not a it's not a downside of expansion. It's not something that would aggravate whatever. So it's just a part of this midfacial separation process. It's not a bad thing to happen.
So are you saying they should have continued?
Yes.
Interesting.
You should have asked your provider what are we expecting? What are the next steps? Because every single treatment plan, and you know that every single provider has their own kind of the plan for further tooth movements. There are certain biomechanics, and if that biomechanics does not support evening out or symmetry, then this is of a concern. If that biomechanics would eventually even it out, yeah, so that's fine. It's separated, so it's not a big deal. It can be repositioned with evening out of those forces.
Awesome. The person said, yes, exactly what Dr. Koval is explaining. So one side moved down and further out. It also showed up in the bite. Back turning moved that part back up and leveled it back out. So that's what they said. I have a question about, so I saw that you use protraction hooks on your MARPE that are connected to the MARPE and not come out on the buccal side. I was curious about when you do that with protraction, how do you prevent downward forces when you're using a face mask, or tipping out the teeth or flaring out the teeth, because the elastics, right, when they come down onto the headgear, aren't they coming over the teeth? Like, how does that work?
So my notion is to put the hooks as close to the center of resistance, where it is, compared to kind of putting it sideways. So that moves the center. We can do both. But again, depending on the initial inclination of that maxillary plane, right? So we have this maxillary plane being slightly more counterclockwise, and it could be positioned in different ways. So that depends on the initial pre-expansion position of that maxillary plane. It depends on actually the I'm a great fan of Crane. In so in yes, yeah, 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 you have. So just because of the I mean, the comfort of wearing it and the all the benefits it provides. Unfortunately, they don't sell it anymore. So you only have to borrow it from somewhere
Yeah.
or kind of to find the person who or the patient who doesn't need it anymore. Yeah, but that's a great thing to do. So it actually depends on the initial location and the kind of inclination of the maxillary plane, and also some of the hooks that I use were initially a part of the kind of the uprighting of the molars, which I no longer use. So this uprighting type
Yeah.
of philosophy referred to braces, which I don't do with my MARPEs or FMEs. I always use aligners. I never ever use braces. It's just my philosophy, just how I love it to handle. And this is why we have those hooks in those positions.
Okay. So just because you have the hooks, let's say, attached to the actual expander and coming forward down under the teeth doesn't necessarily mean it's going to pull down
No, no,
or flare the incisors out.
no,
It's just part of the planning how you work with the patient's anatomy. Okay, that's cool. Yeah, because I've always seen those. I only ever had the ones on the molar bands that came out over the molars. So I wondered about how that works. Um, one more question, I guess, before we wrap up, unless anybody else has one. I don't see any more. You talked about expanding as young as 3. And I went to the Winds of Change event in Chicago. Not sure if you heard of it, but there was a lot of speakers, and Dr. Claire Ferrari is her name, and she's in the Bay Area here in California. She talked about using MARPE on people as young as 6 years old, and so it caused quite the stir and conversation. So I'm curious, like, what expanders do you use at what age? When do you start? Like, what's the earliest age you see a MARPE or you use a MARPE? I'm curious to know about that with your practice.
We do use so we start as early as 3, and with the expanders we use fixed expanders. I
So
do
fixed, you mean like the Hyrax,
I never use Hyrax. Hyrax produces, even though it does produce the mid-palatal separation, it does not produce the proportion of the mid-palatal separation that I would like it to produce. So it produces 70% of teeth tilting rather than 30%, right?
oh, that's crazy.
We don't
Okay.
want
Yeah.
to do that. I never use Hyrex. So I would use something that would produce 70%, even though you cannot completely avoid teeth tilting, but I would use something that would provide those the same kind of amount of bone expansion that I would see in adult patients. And going back to what is the earliest I would do MARPE or MSE or any sort of kind of bone screwed appliance, I have patients that I started. I mean, I did this at the age of 8, 9, and I would do that when. So very nice thing or very kind of curious thing is that I don't know if it's only here in Florida, but I've started seeing patients coming at the age of 9 and 9.5 having the dentition of a 13-year-old. So I would not use the expander, any sort of maxillary expander that would lean against the permanent teeth, just because of the root formation, just because of the kind of the maturation of those roots, not to compromise those teeth. And if this child is in the middle of eruption, I don't have enough tooth support, I would not use the actual tooth-borne expander. So my no-nos would be the maturation of those premolars, like the early maturation of the dentition, loss of multiple teeth due to, I don't know, rampant caries or anything like things like that. And I would go with the skeletal expander. Actually, skeletal expanders are a little tricky in kids just because of the fast bone turnaround and those processes, and TADs are less. They last less in kids than they would last in adolescents.
Is it because they mess with them, or is it because like the gums grow over it really fast?
It's because the bone grows at higher pace, and I believe it's the metabolism of the bone is just so intensive and quick, and it's just different from what we see in adolescence. So TADS tends to wiggle or tends to loosen earlier than
Oh, okay.
yes,
That makes sense because it's
yeah,
so malleable, right?
exactly.
Yeah, I'm actually pretty open to the idea of using it younger. I had an RPE, a or a quad helix. I can't remember. It's Hyrax or quad helix. I don't know if they're different. But when I was 12, and I mean, here I am as an adult still needing expansion. So there's always part of me that wonders if a MARPE or an MSE, any kind of MARPE, was around and available, would that have actually really helped me? Because I never breathed through my nose until MSE. We did have 2 more questions come up. Do you have more time?
Yeah, sure.
Okay, somebody's asking how to fix, a canted occlusal plane.
So that is always dental velar. Maybe not always, but in some instances, again, we do have cases where we play with the orientation, like the transverse orientation of FMEs and MARPEs, kind of to counteract that cant. I want to see more on that. I want to see more kind of observations just to put it into one single study, if this is a pattern or if it's just kind of anecdotal outcomes. So I don't have that answer yet. And I can say for sure that most of the maxillary cants come from dental velar asymmetries. It's just maxilla is always a runway and the mandible is sort of a plane landing against that. So you will see this mandibular inclination, like this transverse asymmetry, if the maxilla provides this maxillary cant. So if the maxilla is canted, crooked, then the mandible will kind of follow and land against that.
Right, which is what we both have, right? I heard you say you have that,
Yeah.
and mine goes over to my right. Um, it's gotten better. Dr. Ting, he fixed my occlusal cant, at least at the molar level, the very back molar level, with TADS and very harsh intrusion. So it was like TADS up here with like power chains and partial braces, and like moved my whole left side up. And boy, that was more painful than the MSC expansion as a whole. So that's how he did it. Is that how you're doing it with your cant?
We don't do that. We use these shape memory aligners and we work with occlusal plane just because of that. All that planning it involves putting the CBCT, the facial scans, and the teeth, like the actual 3D planning into the face. And this is how we work with the kind of tooth movements according to the smile to the patient's face.
Yeah, how do clear aligners affect, like, intrude or extrude teeth for it? Because I'm assuming that's what you have to do, right, to correct the occlusal
Differential.
plane? So how does that work with your shape memory aligners?
So it's always differential. So you have reciprocal forces where you have certain teeth working as an anchorage, and then you plan certain movements into the other teeth. So you don't do simultaneous movements everywhere. You kind of lean against some teeth, and then you do the intrusion. Intrusion is the easiest part. Is the easiest movement that you can achieve with aligners. It's the most straightforward movement. So it's way harder to extrude teeth, which is actually more of a concern for us because we don't want to end up with a gummy smile. And this gumminess type of thing. We'll go over that next time.
Yeah,
But,
'cause I can talk about it, I got it, so it happened to me.
so that is just like a sequential movement. We go segment by segment to
So are
prevent.
you just using pressure, like compression alone from the bite and essentially like elongating something in the aligners to compress it up? Or do you have to use elastics? You're saying you're not using TADS, so you're
No.
not.
In very, very rare occasions, when I use Invisalign, I will do the elastics. Or maybe if I still have MARPE, I could play with the with elastics that go across the dental arch from the MARPE to the buccal tabs. But this is very rare, and usually patients have a lot of discomfort because of that irritation around the tabs. So we're no longer using that, and we have really good results with this kind of post expansion.
Wow, that's awesome. Because yeah, like I said, my intrusion was brutal. And the TADS, like, they get way more inflamed and irritated than MARPE TADS. So, um, okay. Are there differences in expanding patients with a long face versus short face?
Yes. And it's so if we're talking about the patients with a long face, there's always some sort of kind of airway concern with that, and the retrusion of the mandible, and the kind of this bounce back here. So we always talk to the patient in advance. Hey, we will have this MARPE expansion, and you, above anybody else with any other sort of malocclusion, you will experience this mandibular kind of drawback almost immediately after the expansion, just because we have this inclination of the occlusal plane that we have to deal after. And that inclination is the most challenging part, and that takes the most time. That's why my treatment plans are always 2-year treatment plans, and they're never 1-year treatment plan, because we work a lot with the occlusal plane. So that's why we do expand. And there was like a very widely accepted idea that some patients are not good candidates for expansion, like long face patients with the dolichofacial profiles. Everybody is the candidate, I mean, based on the symptoms and based on specific predictors. But what relates to post expansion, some patients are just more challenging, and it has to be clear to both parties, to the patient and to the provider, that hey, this is a lot of work that needs to be done, and we have to be very patient with that. And we both know that what are we expecting, and what is the kind of the timeline for that, and what would be the little milestones of during that process.
Okay, so it sounds like a short face is pretty straightforward, but when you enter the territory of a longer face, it's a more complex case, and it's doable. It's just going to take more time. Okay, it's good to know that you're not turning people away just because we developed poorly. I'm a long face girly. Why? Thank you. Right back at you. Somebody says, "What about a short face but with a small airway?" It sounds like that you guys are easier than long faces.
Yes, and usually, again, class 3 cases are more kind of rewarding, because we have a lot of benefits we're getting right after the expansion. We see a lot of improvement right away. So this is like a wow effect within the 2 or 3 months with the class 3 cases.
Awesome. Well, thank you so much, Dr. Koval. Hopefully, we get a chance to talk about some gummy smiles. I think a lot of people are interested in that, because we get that question also. People are afraid of that in the Facebook group. So, sending it back to you, Patrick.
Thank you. That was amazing. Thank you both so much for answering all those questions and sharing the insights. And thank you, everyone, for tuning in and asking all those beautiful questions. The next live with Dr. Svitlana Koval will be March 23rd.
Correct.
Do we have a topic yet?
Yeah, we have this downward rotation.
Gummy smiles.
There you go. So be sure to tune in on that. And I'm wishing everybody the good rest of day. So take care, and we'll catch you soon.
Thanks.
Bye.